Picture this. You are sitting at the kitchen table. Your pill is in your hand, same as every morning for the past 2 years. You swallow it with a sip of water and move on with your day. You are doing everything right. You are consistent. You are responsible. And yet somewhere in the back of your mind there is a question that keeps surfacing. A cough that arrived a few months ago and never left. Ankles that look different than they used to by the end of the day. A moment of dizziness when you stand up that you have quietly started planning around. And each time you notice one of these things, you tell yourself the same thing. It is probably nothing. It is just getting older. It is not related to the pill. Here's the part that most people never find out until something forces the conversation. In many cases, it is related to the pill. Not because the medication is wrong for you, but because nobody ever sat down and explained what these medications actually do inside your body, what they can cause, what the warning signs mean, and critically, which symptoms are a minor inconvenience versus which ones require you to stop what you are doing and call for help right now. That is exactly what we are going to do today. Not in the vague way a pamphlet explains it, in the real, specific, practical way that actually changes how you manage your health from this point forward. There are 3 blood pressure medications that more people over 60 take than almost any others: a calcium channel blocker, an ACE inhibitor, and a drug from a class called ARBs. Millions of people are on one or more of these right now, and the vast majority of them could not tell you how each one actually works, why each one causes different problems, or why the name on their bottle matters far more than just being a label. That gap in understanding is not your fault. It is a 10-minute appointment trying to cover something that deserves a much longer conversation. So let us have it now. Start with the calcium channel blocker. This is the medication that relaxes the walls of your arteries. Think of your arteries as tightly wound rubber tubes. This drug tells the smooth muscle inside those tubes to loosen up, which reduces resistance and lets blood flow through with less pressure. That is the intended effect, and it works well. But here is what the drug cannot do with the same precision. It cannot relax your veins in quite the same way, and that difference matters enormously for what happens in your legs by the end of each day. Your arteries carry blood down to your lower legs. Your veins carry it back up. And when the arteries relax and deliver blood more freely, but the veins do not have the same response, you end up with more blood arriving in the lower legs than is comfortably leaving. The pressure in the tiny blood vessels near your ankles and feet builds up, and eventually that pressure pushes fluid out of the vessels and into the surrounding tissue. What you see on the outside is swollen ankles, socks that leave deep impressions in your skin, shoes that feel tighter than they did a year ago, and legs that feel heavy and full by mid-afternoon even when you have not done anything particularly strenuous. Here is where this becomes genuinely dangerous, and not for the reason you might think. The swelling itself, in most cases, is manageable. What creates real risk is how people respond to it without knowing what it is. Some people see the swelling and quietly stop taking the medication without telling their doctor, and their blood pressure quietly rises back up while they feel like they made a sensible, cautious decision. Others drink less water because they assume they are retaining fluid and need to cut back, which is the opposite of helpful and can create its own set of problems. And some people simply endure it in silence for months, gradually moving less, assuming something serious is failing, and losing quality of life over something that had a solution the whole time. If your legs swell on this medication, that is not something to accept as your new normal, and not something to manage on your own by stopping the pill. It is a conversation your doctor needs to hear because there are often adjustments, alternatives, or simple strategies that change the picture entirely. But none of that is possible if you stay quiet. Now let us talk about the ACE inhibitor, the medication that works by blocking a specific enzyme your body uses to tighten blood vessels. By blocking that enzyme, blood vessels stay more relaxed and pressure drops. It is an effective mechanism, and this class of medication has decades of research behind it. But it comes with one side effect that is so consistent, so well documented, and so frequently misidentified as something else that it deserves its own careful explanation. The cough. Not a wet cough, not a productive cough, not the kind that comes with a cold. A dry, persistent tickle deep in the throat that tends to be worse when you lie down at night and does not respond to anything you try. No cough drops, no allergy medication, no throat spray makes a meaningful dent in it. And the part that makes this so easy to miss, it often does not appear right away. Some people develop it within weeks, others take 3, 4, or even 6 months before it shows up. And by that point, the connection between a medication they have been taking without any apparent problems and a cough that seemed to appear from nowhere is almost never the first conclusion anyone reaches. So the cough gets attributed to dust, to seasonal allergies, to a lingering respiratory irritation after a cold, to acid reflux. A chest scan comes back clear. Antihistamines are tried and do not help. Months pass, sometimes more than a year, and in the meantime, the sleep disruption accumulates, the fatigue compounds, and someone is living with a significantly reduced quality of life over something that had a simple explanation and a straightforward solution. If you have been on an ACE inhibitor for any length of time, and you have developed a dry, persistent cough that arrived at some point after starting the medication, even months later, that timeline is worth discussing with your doctor. The solution when this connection is confirmed is typically to switch to a different medication class that works through a similar mechanism but does not cause this reaction. The cough often resolves within 2 to 3 weeks of making that switch. But here is where I need you to pay very close attention, because there is a completely different symptom in this medication category that is not a nuisance and is not something you discuss at your next scheduled appointment. If you are on an ACE inhibitor and you notice swelling in your lips, your tongue, the inside of your mouth, your face, or your throat, particularly if that swelling is making it harder to swallow, or if your breathing feels different or more difficult, you do not wait and see. You do not take an antihistamine and monitor it for a few hours. You call emergency services immediately. This reaction is rare, but when it occurs, it can progress faster than most people expect. It can compromise your airway, and the window to intervene safely closes quickly. A dry cough and throat swelling may both sound like throat-related symptoms, but the distance between them in terms of urgency could not be wider. The cough is a conversation. The throat swelling is an emergency. That distinction is not something to be vague about. Now let us talk about the ARB, the angiotensin receptor blocker, which targets the same blood pressure regulation system as the ACE inhibitor, but works at a slightly different point in that pathway. This class generally does not cause the persistent cough, which is one of the reasons it is sometimes chosen as an alternative. But it carries its own important consideration that is hiding inside a product that millions of people purchase specifically because they believe it is the healthy choice. One of the effects of ARBs on the body is that they can cause potassium levels in the blood to rise. For most people on appropriate doses with regular monitoring, this stays within a safe range. But here is where the picture changes. Potassium does not only come from bananas or from supplements labeled with the word potassium. It is the primary ingredient in many low-sodium salt substitutes, the products sold right next to regular table salt in every grocery store, often with language on the label suggesting they are better for your heart. Someone who has been told by their doctor to reduce their salt intake purchases one of these products uses it generously on their meals because it seems like the responsible thing to do, and is now introducing significant amounts of potassium into their body every single day while taking a medication that already raises potassium levels. The combination can push potassium high enough to interfere with the electrical system of the heart, and the symptoms that signal this are easy to dismiss. Unusual muscle weakness, persistent fatigue that does not improve with rest, a cramping sensation in the legs, tingling in the hands or feet, or an irregular fluttering in the chest. The troubling part is that sometimes these symptoms are subtle enough to go unnoticed entirely until the situation becomes more serious. If you or someone in your household has switched to a potassium-based salt substitute and is taking an ARB or an ACE inhibitor, that specific combination needs to come up in a conversation with a prescribing doctor. This is also relevant for certain electrolyte drinks, some meal replacement products, and sports recovery formulas that carry meaningful potassium content. They are not prescription products, so no one thinks to mention them. That is exactly why they matter. There is another scenario that does not get nearly enough attention, and it affects seniors disproportionately because it involves the interaction between these medications, and something as ordinary as being sick for a few days. Not seriously ill, just a stomach bug, a few days of nausea or diarrhea, a stretch of hot weather with heavy sweating and not quite enough to drink, reduced appetite that keeps you from eating or drinking normally for 2 or 3 days. When you are well hydrated, your blood pressure medication is calibrated for the internal environment of a body in its normal state. When dehydration occurs for any reason, that same dose acts differently. Blood pressure can drop further than intended. The kidneys, which are already working harder because of reduced fluid volume, are placed under additional strain by medications that affect how blood flows through them. Dizziness, faintness, weakness, and acute kidney stress can develop more quickly than most people anticipate. The medication did not change. Your body's conditions changed, and the drug is now operating in a context it was not designed for. This is one of the most practical things to understand about long-term blood pressure management. Having a clear plan from your doctor for what to do when illness or dehydration occurs, whether to hold a dose, when to call for guidance, which symptoms should prompt immediate attention, is not an edge case piece of information. It is essential. If you do not have that plan, ask for it at your next appointment. The specific question to ask is this: what should I do with my blood pressure medication if I am unable to eat or drink normally for a couple of days? That question takes 30 seconds, and the answer could matter enormously at exactly the moment you need it. There is one more situation that walks into the gap between common sense and medical reality in a way that surprises a lot of people. Arthritis is extremely common in the age group most likely to be on blood pressure medications. So is the habit of reaching for an over-the-counter anti-inflammatory, the kind of pain reliever that has been in medicine cabinets for decades and feels as ordinary as any household product, the kind that anyone can buy without a prescription. But your kidneys do not distinguish between a medication that came from a pharmacy counter and one that came from a shelf. They respond to chemistry, and the chemistry of anti-inflammatory pain relievers, when combined with ACE inhibitors, ARBs, or diuretics, reduces blood flow to the kidneys in a way that, especially alongside any degree of dehydration, creates real risk of kidney strain or injury. This combination is not rare. It is one of the most common preventable kidney-related situations that develops gradually without anyone realizing the connection. If you manage regular pain from arthritis, joint problems, or back issues using these kinds of over-the-counter anti-inflammatories, and you take any blood pressure medication, bring it up directly with your doctor. Ask whether there is an alternative approach for the pain that carries less risk for your kidneys. Acetaminophen, topical treatments, or other approaches are often viable options. The goal is not to simply endure the pain. The goal is to find a path that addresses both things without creating a third problem. Let us spend a moment on something that most people on blood pressure medications experience regularly and almost universally underreport because it seems too minor to bring up. The brief dizziness when you stand up from a chair or get out of bed. The world tilts for a second. You reach for something stable. Then it passes and you move on. It feels like nothing. It feels like just getting up too fast. And because it passes quickly, it never makes it into the conversation at a doctor's appointment. Here is what that moment actually represents. Your blood pressure medications are lowering your pressure throughout the day. When you stand up quickly, your cardiovascular system needs a moment to redirect blood upward against gravity. Normally, this adjustment happens almost instantly. When blood pressure is pharmacologically lowered, that adjustment can lag, and for a few seconds the brain receives slightly less blood flow. That is what you feel as dizziness. And for an older adult, a few seconds of dizziness is a meaningful window of fall risk. The consequences of falls in this age group are well documented and serious. The practical adjustments are simple. Rise more slowly. Sit at the edge of the bed for a few seconds before standing. Keep a hand near something stable. Give your body time to catch up. But beyond the practical habits, dizziness that is frequent, that is not improving over time, or that tips into a feeling of near fainting, those patterns deserve to be reported and reviewed. The dose may be able to be adjusted. The combination of medications may need to be reconsidered. But the adjustment cannot happen if the symptom is never mentioned. The last thing worth addressing directly is home blood pressure monitoring, because it creates unnecessary anxiety for a significant number of people and sometimes leads to impulsive decisions that make things worse rather than better. Blood pressure is not a fixed number that sits still. It moves constantly in response to things that have nothing to do with your medication. How you slept, whether you have had caffeine, whether you are in pain or stressed, whether you just walked inside from the cold, whether you spoke right before sitting down to take the reading. A high number on a stressed Tuesday morning after 4 hours of sleep does not mean your medication has stopped working. A lower number on a calm, well-rested morning does not mean the dose is suddenly too strong. What gives your doctor actually useful information is a pattern. The same arm, the same time of day, after 5 minutes of sitting quietly recorded over days and weeks. When monitoring is inconsistent and individual readings trigger emotional reactions, the decisions that follow tend to be unhelpful. Extra doses taken because one reading looked alarming. Skipped doses because one reading looked fine. Neither of these serves you, and both create exactly the kind of variability in your system that makes blood pressure harder to manage over time. These medications work through steady, consistent presence. They are not designed to be taken reactively or adjusted based on a single reading. Monitor with a method, record what you find, bring it to your appointments, and let the pattern tell the story, rather than any single number on any single day. What I want you to carry out of this is not fear about the medications you are taking. The opposite is true. These medications, when understood and managed well, provide real, meaningful protection for your heart, your kidneys, and your blood vessels over time. What they require in return is not just consistency in taking them. They require an informed, communicative relationship with the people who prescribe them. Knowing what each medication does and why. Recognizing which symptoms are expected and manageable versus which ones require immediate attention. Understanding how your lifestyle, your diet, and your other health management choices interact with what is in that pill. You have been responsible enough to take your medication every single day. You deserve to understand it as well as you take it. Share this with someone you know who is managing blood pressure, because this is the kind of conversation that matters and happens far too rarely.